Assalamu alaikum, Sabah AlKharji جميعا. Welcome everybody to our second atrial fibrillation symposium. Since we started doing this last year, my name is Dr. Samah AlKharji. I'm one of the cardiac electrophysiologists and the head of cardiology department in Al Dabbous Cardiac Center in Adan Hospital. So it is my pleasure to be amongst you today to raise awareness and discuss one of the most common cardiac arrhythmias in cardiology. And I'm here among great colleagues and also aspiring cardiologists and physicians from different specialties in the field. And it's also my pleasure this year to welcome expertise from Oman, my colleague Dr. Mohammed Al-Rawahi, and one of my esteemed colleagues who will be video conferencing from the US. So we started doing this last year, so I'd like to welcome you. Is it there? Okay. And last year we also had a great contribution from our hospital and other hospitals, and also it is a disease that connects different subspecialties, so there's something that connects us all. And we can only do this through sharing experiences in order to help manage our patients. So atrial fibrillation is not only a disease for cardiologists or electrophysiologists, everybody is involved in the management of these patients, including anesthesiologists, even surgeons. And the bulk actually of these patients are being managed or seen firsthand probably by our colleagues in the family medicine as well. So this year we want to continue, and hopefully we can keep going on to update ourselves on the management of atrial fibrillation. So we'll be covering different aspects of the management of this disease. Definitely we cannot cover everything as it's vast and continue to evolve, but this will be a talk for physicians from all aspects of management, and also including nursing and also technicians as well. So we'll talk about oral anticoagulations, what are the indications, which patients are candidates for anticoagulations, and is there any specific precautions for patients at high risk? Can they be anticoagulated or not, especially patients with renal failure? How can we manage patients with atrial fibrillation who have acute coronary syndrome or chronic coronary artery disease? In addition, we'll be talking about the burden of disease in terms of stroke. Stroke is a disease that's a burden on patients and also significant morbidity and mortality in our society. So Dr. Peter will be discussing the burden of stroke in Al Adan Hospital and also give us an overview on how to manage patients with a new diagnosis of AF in the context of stroke. When do we start anticoagulation and how do we navigate through managing these patients? We'll discuss patients who are at high risk of bleeding, whether they have an intracranial hemorrhage, and what can we do for these patients when thromboembolic risk is high and they need the benefit of oral anticoagulations. The session on wearables and the diagnosis of atrial fibrillation will be delayed, but we'll discuss, since we're in 2023, everybody has an Apple Watch and some sort of wearable piece of technology that they can diagnose the disease, and how can we use this in our favor. And then we'll be talking about what do we need to know about how to manage the atrial fibrillation itself, from the emergency room, continuing on to inpatient management. Do we need to rhythm control, rate control, and what kind of rhythm control? And we'll hear about experiences from different aspects of the world as well, so that we can learn and evolve also in our hospital. And at the end, we know that AF is not a standalone disease. It can be actually a symptom or a manifestation of more chronic disorders, like sleep disorders, heart failure, obesity, and also aortic stenosis. And we have colleagues from respirology. Dr. Seyman will touch up on that, as well as weight management, specifically tailored to patients with atrial fibrillation. How does that affect patients' prognosis as well? We'll discuss how prevalent atrial fibrillation, aortic stenosis is, and also we'll talk about heart failure and atrial fibrillation. And by this, we'll have an overview, or let's say AFib at a glance, at least, so you'll be able to take to your practice what we learned today and think about atrial fibrillation when we see your next patient. Just taking a minute. So, as I said, I come to you from the Boost Cardiac Center, part of Al-Adan Hospital. Yeah, it is. It's taking some time. But we'll get there. All right, perfect. So as you can tell, I'm very passionate about atrial fibrillation because I feel like it's a disease that should be in the category of hypertension, diabetes, atrial fibrillation. It is more common than what we think, and there's a little bit of, we're not doing it justice, and a lot of patients don't know about it. So the goal of this, maybe there not be a lot of new science today, but to shed light and specifically discuss about this common arrhythmia. Its prevalence is high, and it's expected to increase in the upcoming years, and is associated with high degree of morbidity and mortality in terms of ER visits and hospitalizations due to attacks of rapid ventricular response. So what is atrial fibrillation? It is an irregular arrhythmia that you all know that affects the atria. And it's, till now, the standard of diagnosis is the 12-lead ECG. So no matter what technology, at least until now, no matter what technology we're using, whether this is a single rhythm strip or an Apple Watch alert, still diagnosis, we need to have that 12-lead ECG to diagnose it, but patient symptoms should not be taken into without serious consideration. So we need that 30-second strip to diagnose that atrial fibrillation. So from what you can see, to compare the normal rhythm and atrial fibrillation, where there's a disorganized atrial activity that can be associated with significant symptoms. So the global burden of disease is high, and it's estimated that about 1 in 3 patients or individuals above the age of 55 will be affected with atrial fibrillation. Now, I put a circle here about our region. There are some data, but it's definitely not comparable with our Western or international data. So hoping by doing more of these talks and conferences that we can gather efforts so that we have more evidence, so we can serve best our patients. So there are some data from mostly WHO or the CDC that are estimating our populations, because of increasing age, obesity, hypertension, that the percent increase expectations for atrial fibrillation is going to increase over next years, and this was comparison between 1990 to 2019. Well, you can see a lot has happened between those years, whether diagnosis or actually knowing about atrial fibrillation in our region peaked during that period, but there was a significant increase, up to 100% or 200% increase from 1990 to 2019. Atrial fibrillation may not cause direct mortality, but definitely affects patients' quality of life and can result into how do we measure burden of disease is by measuring disability adjusted life years. This means that absence from work, inability to perform daily activities, and also years lost due to the disease itself, and this is significantly high. We cannot compare atrial fibrillation, obviously, to burden of disease caused by ischemic heart disease, but it is something that it is on the rise. And the prevalence and the DALYs are increasing with age and also throughout the years. How about in our countries, in the Middle Eastern and South Asian, there are some data available to describe, which are mostly observational in essence, and also registries. So this is, So that was a good article that I came across that summarizes or kind of collects all the data that have been published about atrial fibrillation, or studies in the atrial fibrillation, whether this is registries or non-registries. And it's a good reference to have a ballpark on where do we stand. Again, mostly inpatient population, because most likely of easy accessibility of the data. How about from our hospital? This is a study that was done in 2005 that showed ER visits to our hospital, patients with acute atrial fibrillation or symptomatic atrial fibrillation, whether this is persistent or acute, was almost over 3 months, about 4%. And most of them carry a burden of ischemic heart disease, hypertension, and diabetes. All right, so again, that study that we discussed by Salam et al., it collects all the studies that are done in the Middle Eastern and South Asian populations. And if we're gonna just shed the light on the single and multi-center registries to show that the prevalence ranges, again, mostly in patients, between almost about 5 to 10, 15%. So this is for all inpatients. And as you can see, at that time, the mean age was slightly younger than Western population, was in the 50s compared to 65 and above. But I think from now, as we can see, the age is also becoming more comparable. A local registry that was done, preliminary data that we did in our center with some of the aspiring cardiologists in the audience, that our mean age also close to 65, at least from patients following in Al Adan Hospital. So again, yes, AFib is common and it takes a village, even if you don't see it, but patients follow a lot of specialists in the background. So atrial fibrillation is irregular rhythm where you don't see a P wave and it's irregular. What is not atrial fibrillation? Sometimes we have to pay attention, repeat a couple of ECGs, so we exclude artifacts. And atrial fibrillation flutter is not atrial fibrillation, although management is almost similar, but it is a different kind of animal we're dealing with. And frequent premature atrial contractions are not atrial fibrillation, although we know that a higher burden of PACs on the long run can predispose patients to AF, but these patients are not eligible for oral anticoagulation and the rest of the treatment. So how do we describe it, atrial fibrillation? So paroxysmal atrial fibrillation is an episode that is short and does not last. It's less than 7 days and close to 30 seconds or more. Persistent is when it lasts 4 days, but it's less than 1 year. So chronic atrial fibrillation is out of the picture. It's persistent, long-standing persistent when it's over 1 year, and we may be considering rhythm strategies. If it's permanent, then there is no plan for rhythm control strategies. There are other terminologies coming up with the literature now, post-op atrial fibrillation. Sorry, this is scratched for some reason. And subclinical atrial fibrillation. This is mostly for the EP electrophysiology world, where it is detected on pacemakers and ICD, where the patient does not feel anything, but we see it on device check. So abandoned terminology, lone AF, is abandoned. Valvular, non-valvular, it is still there, but all of the above we're going to talk about today is non-valvular atrial fibrillation. And as I said, chronic atrial fibrillation is out. Valvular, non-valvular still exists, but what is valvular? So valvular is anything that is moderate to severe mitral stenosis, so not aortic stenosis. Or any mechanical valves. And why is that? Because management differ. Patients who have mechanical valves or has moderate to severe mitral stenosis, we cannot treat them with the direct oral anticoagulation. And we're probably going to hear about it today, that we're still trying to show that DOACs can be used, but so far the evidence is against. So why does atrial fibrillation happen? What's the reason behind it? Again, there's no single cause. It's a multi-system disease and multiple risk factors. You may have the predisposition to have that arrhythmias, but it's definitely all of the above. There are some modifiable risk factors like obesity, smoking, alcohol, dyslipidemia, physical inactivity, and also chronic kidney disease, diabetes, hypertension, anything that does damage to the heart, whether this is surgery, heart failure, any structural abnormalities in the heart can definitely predispose to that. The kind of back and forth relationship is with heart failure and valvular heart disease. It can be a cause and effect relationship that we'll hear about for the rest of today. So there are also some recent terminology is AFib can be primary, meaning that its patient just comes in with atrial fibrillation, or secondary, meaning that patient has the substrate, they have diabetes, hypertension, ischemic heart disease, they have a lot of substrate and they just need something to expose that atrial fibrillation, whether this is surgery, sepsis, pneumonia, and then in hospital, I'm sure a lot of us see those kind of patients who are not known and all of a sudden they have atrial fibrillation, compared to those who have nothing, but they have atrial fibrillation foci or triggers to cause that. And something to keep in mind that when patient comes in with a single episode, we know that these episodes are recurrent, and over time they will go from paroxysmal, frequent episodes, persistent, and permanent. And about 15% of these patients will have that transition over 1 year. So this is just an illustration of what I was just talking about. So when you have a lot of substrate, you just need a trigger to show that iceberg, whether when you have not a lot of substrate, this can be reversible. If a young patient, 25, with no risk factors, have a pneumonia and they have AFib, the risk of recurrence is probably less, and this can be considered as reversible compared to an elderly patient with a lot of substrate or disease. This atrial fibrillation may be there to stay. The same principle, this is from American guidelines, showing that you need substrate and triggers, and this interaction will show clinically when the patient has a trigger like admission for non-cardiac reasons. And management is essentially the same, but the initial focus is to manage underlying risk factors or the known disease. Pneumonia, manage the sepsis, rather than aggressively managing the rate or the rhythm at that time if there's obviously no hemodynamic instability. So why does this happen? What is AFib? What happens in the atrium? So it triggers, meaning that we have the atrial muscle itself, and there are actually fibrous deposition in the cell at the cellular level, and this causes electrical remodeling at the beginning. These foci are the triggers for this atrial fibrillation, and we know from we have evidence showing that at the beginning of disease, these triggers are mostly from the sleeve of the pulmonary veins. So these are the pulmonary veins. We have, at least in most of the population, we have 4 pulmonary veins, and that sleeve where the pulmonary veins enter the left atrium are the initial trigger for patients with, let's say, few or the beginning of the disease. With time, this electrical remodeling, we have more fibrosis in higher burden that will eventually cause structural remodeling, meaning that the left atrium will dilate. This left atrium dilatation can cause eventually mitral valve disease, heart failure, and so on and so forth. The timeline is different from every patient. So the more fibrosis you have, the more likely you have atrial fibrillation, more likely it will be actually persistent. So intervention is needed earlier on from in the disease. This is essentially showing what I was just talking about. So when you have a lot of electrical and then structural remodeling, stretching of the left atrium will affect the mitral valve, and you will have mitral valve disease. The picture of atrial myopathy causing mitral valve disease is different than other diseases causing the mitral valve disease. It's usually central regurgitation with obviously no heart failure, no other causes of mitral valve disease. AF and heart failure, they have this interesting relationship. So you can say which is the chicken and which is the egg. So atrial fibrillation can precipitate heart failure, causing tachycardia-induced cardiomyopathy, and the rest is true. So if you have heart failure, you can be at risk of atrial fibrillation. And managing one disease affects the other. And we know atrial fibrillation management or rhythm control in patients with heart failure improves their mortality, their disease actually management, and also quality of life. Skip that. And also talking on the evidence from our region, especially Gulf region, including Kuwait, this was also a study including patients with atrial fibrillation who were admitted with acute coronary syndrome. It's just to show the disease profile or the background profile for these patients. as I showed earlier, disease, mean age at that time, it was in the high 50s, low 60s, and the most common risk factor that we see a lot is hypertension, actually. Yes, diabetes, but more hypertension. What are the symptoms of atrial fibrillation? So atrial fibrillation, surprisingly, doesn't always present with palpitation. You would think that this is the most common symptoms. Yes, it is common sense, but we see a lot of patients who are coming in with just fatigue and shortness of breath, difficulty exercising, some sort of anxiety or panic attacks. And most of the time, not most of the time, just we should not disregard these symptoms and think about it at the back of our heads. Chest pain, that can be sometimes thought of as acute coronary syndrome, but it can be caused by atrial fibrillation just because of the coronary filling, and also dizziness. And a lot of patients, they just have this ECG done for whatever reason and pre-op investigation or for pre-employment, and they have this atrial fibrillation. So symptoms are not essentially just palpitation. Any symptom, vague symptoms like fatigue and difficulty exercising. From, again, this registry that collects all the Middle Eastern and South Asian population symptoms, it showed that here the most common symptoms was palpitation, also and dyspnea. So these are the top of the symptoms that was collected from these prospective trials. Just to have an overview on how do we manage these patients, you'll hear about this for today's talk, but essentially, when you think about atrial fibrillation, I like this algorithm from the European Society of Cardiology just to make it easier. We need to ABC, to anticoagulate and avoid stroke, control, better control of rhythm, and to me, this is the most important part of management is control risk factors. Patients with AFib cannot have high blood pressure all the time, even if AFib rate or heart rate is under control. Lifestyle and obesity needs to be controlled, and screening for sleep apnea is important. AF management should be integrated, and patient is at the top of this pyramid. Patient-centered care, rhythm control, anticoagulation, dosing of anticoagulation, and the control of risk factors. Patients should be at the center for the management of atrial fibrillation. And by this, I end my introduction, and thank you very much.